All right, good morning, everybody. Welcome. It's Christmas Eve here, December 24th, 2019. I'm here with Dr. Patrick Tropiano of Marseille, France. Good morning.
Morning.
Bonjour.
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 Bonjour à tous.
I just want to kind of give the front story of how and why Patrick Tropiano is here today. Let me get this camera fixed. So we met, it's probably been about 2 years now. And, I got word from you, from Dr. Fernandez, that you do most of the training for FH orthopedics. And we met in Le Mans, France. And after Le Mans, and I don't know if you know this, me and my wife were together, and I got in my car and I drove to Marseille and met you and came up to your clinic. And I think you thought I was kind of nuts because I'm talking to you about this group. I'm like, listen, I've heard about you and I've heard the fantastic things you do, and you travel the world training surgeons for FH orthopedics. And I said, I want you to be a part of this group. And you kind of looked at me, and I think you kind of thought I was a little nuts. And I think the group at the time was maybe right around 1,000, and obviously we've probably doubled since then. And going forward, we met again about 4 months ago in Chicago, and at the NAS meeting, he says, "Hey, I want to talk to you." And you finally said you were able to kind of get your hospital on board with doing international patients, which was fantastic. And you were interested in joining the group. And I have to say, I have so much gratitude for you doing that, because you've been somewhat instrumental in helping a lot of people and giving a lot of great advice that is out of my comprehension. So, and I've learned a lot of things from you, and I just want to say greatly appreciate it. And you now are taking some international patients, and I think you've got about 3 or 4 scheduled here in the future.
Yeah, 2 for the moment.
2 for the moment.
Yeah.
So we'll talk about that more towards the end. So we'll just do a little profile about you for right now. What made you, going back to your teenage years and going forward, what made you decide to get in to what you're doing now? What made you decide to get into spine? And then, talk about us on the relationship, because in France, you guys learned the A-lift before anything. And then I'm sure you progressed, 25 years ago into, total disc replacement, or we call it artificial disc replacement. And let's just talk about that, talk about your schooling. And we talked about that when I was in your clinic as well. And we'll kind of go from there.
Yeah, I started my residency in orthopedic surgery. And once I met my mentor, it was René Louis. René Louis is one of the pioneers of spine surgery for worldwide. In France, that the story of the French spine history is done by 3 guys. One was Roi Camille in Paris. Second one was Sénégas in Bordeaux. And the third was René Louis in Marseille. René Louis did all the surgery of the spine, and he was anatomist, and he described many things on spine. And it was my mentor. And when I met him the first time, I discovered the spine surgery, and I say, okay, I want to do that. And it was during my residency. I was around 28 years old. And then I followed him. I was with him during 70 years. And I did a lot. I learned a lot. Each day it was a learning time. And I worked with him on anatomy, on biomechanics, on clinics, and everything. And it was very nice. It was my mentor. And then I tried to follow what I learned from him, but it's difficult nowadays because the young surgeons prefer to look at the video than to listen to the whole school boy. That's it.
And then, how long have you been doing disc replacement?
I start the history of disc replacement start with Thierry Marnet in Montpellier. Thierry Marnet is a good friend of mine, and he was the conceptor of the Pro Disc. And during the first generation of Pro Disc, we met, and then we worked on the Pro Disc first generation. And I did the publication on GBGS. It was in 2002, I guess, yeah. And it was the first result of 10 years follow-up of the patient with the Pro Disc 1. Then the Pro Disc evolved to the Pro Disc 2. And I worked with him on the improvement of the ancillary material. And after all, we work on the cervical and etc. And Thierry Marnet was for me the guy who I start with him with the disc replacement. You know, in French, the first prosthesis implanted was the Charité in the year 1982-83. It was the first attempt with the ADR in France, with the Charité.
Yeah, it's a lot way before our time, before it ever hit the United States. And you know, I met Theory too as well in Toronto a couple years ago at ISASS. Are you going to Puerto Rico? Have you decided yet? Here in February?
Yeah.
Are you going?
In Toronto? No, it was in Montreal.
No, it was in Toronto.
SAS?
I said, yeah, 2 years ago.
SAS? In ISAS.
ISIS, yes.
Yeah.
So yeah, and you may have been there. I just
I was there. Yeah.
He was you know, working there with Sentinel Spine, and we had yeah. So he was kind of talking to surgeons about it there, and I had a kind of long conversation with him. So did you implant any Charité, or was it just all Pro Disc?
I implant one Charité. Charité is a very great concept, but for me, it's like a nucleus prosthesis.
Yeah.
Not a prosthesis for advanced degenerative disease.
Yeah.
You know what I mean? But it's very nice. It's very, very, very difficult to implant, and it's it's for nucleus disease only.
Right.
Very good bone quality, no osteophytes, very, very simple case.
Right. Just basically one level. You know, we had a woman from France in our group, and I haven't seen her. She had a 2-level Charité, and she had it for 17 years. And, you know, she was doing yoga and everything. And all of a sudden, you know, they kind of do that explosion where that inner core kind of shoots out, and that's basically what happened to her. And I don't know where she decided to go. But then let's talk a little bit about how many artificial discs have you implanted over your course?
I don't know exactly, but it's around 4,000.
And out of those 4,000, you mostly done Pro Disc and the ESP. Has there been any other ones along the line that you've implanted?
I did also the Mobi-L. I used the Mobi-L from ADR. I was the first to implant it.
Oh, no kidding.
Because I was very close to LDR in the time, and then I did a lot of them. I tried also the prosthesis from Spine Art.
Yeah, I was just trying to remember that name, the Spine Art one. What is that called?
Is Bagheera.
Bagheera, yeah.
I did 3 cases of Bagheera.
Cervical or lumbar?
Cervical and lumbar, the both.
You did both.
Yeah, it's not too bad. It's not a bad process, but for me, I don't like it to hammer it too much. And then with the Bagheera, you have to implant it very hardly, and then I don't like it to hammer too much.
And is there anything else along the way? I'm trying to think anything else you might have seen. Is that it?
No. Again, what is it?
I'm trying. So then you're also doing the new Pro Disc without the keels. What is that called?
C'est Vivo.
Yeah, the Vivo. Yeah.
I use a lot of C Vivo. Yeah, the case I send you.
Yeah.
The level about the C Vivo.
Are you using that mostly all cervical?
Yes, I use it. But the kill is a good thing.
Right.
In case of multi-level disc replacement, the kill is very interesting just for on the level below. Yeah, the lower level you have to put kills. It's better than without kill because there is a big lever arm, and when you put multi-level prosthesis, you increase the stiffness of the spine, and then most the spine is stiff, more the implant is unstable, and the reason why we saw in some cases of multi-level disc replacement in cervical, some kyphotic positioning of the prosthesis on the lower prosthesis, and also some sliding effect on the prosthesis due to the lever arm and the stiffness of the spine.
What have you, let's talk about cervical a little bit. Let's talk about the Mobi C. Let's talk about the Pro Disc. And then the ESP.
I use a lot of Mobi C.
What, and I think I know this answer. Is the Mobi C probably the most difficult to place?
No. Why? Why the most difficult to place? Why do you say that?
Well, because from some cases here and some patients, we see that the placement is not perfect, and then you see that kilter happen a lot with that Mobi C. And
yeah, the problem is, in fact, the problem of the mobile core. Sometimes the core is blocked in a position, and then you have no more motion, and then you have only translation. And if you have only translation, you push on the end plate, and pushing the end plate, then you have loosening of the prosthesis, and then sometimes you have a bad positioning of the prosthesis.
Yeah, because you've seen it in our group a few times. There's been some patients here, and I think mostly in the States, that the positioning is not the best. And so I guess that was my question. So out of the three, which one is the most difficult? I mean, I guess I know you've trained, we'll talk about this, you train surgeons both in the Pro Disc and the ESP, but when you're training a surgeon, what is usually, in your mind, what is the easiest to train someone and what is the most difficult?
I think the problem is to train people, surgeons, to disc replacement. It's completely different than fusion.
Sure.
Because you need to have motion. And if you want to give motion, you have to make a very good release, posterior release into the kernel. That you have to remove all the ligaments, you have to remove the annulus, you have to remove posterior ligament, and you have to remove all the bone just to make the good release. And then you have to distract, and then the distraction is very important. And if you have a parallel distraction, it's very good. But if you have slight kyphosis or hyperlordosis in the level, if the end plate are not parallel, you have not a bad distraction, and the motion will not be good. And then also the insertion will not be good. Then the most important is to put the implant the most posteriorly as you can, and also the wider, the larger to have the best print on the end plate.
So let's talk about if a patient is interested in coming to you. What do you want to see? I mean, obviously you prefer to see the patient in person, but as far as history, I mean, obviously you're looking for history. What have they all done? What is, from therapy on to injections and whatnot, but also what kind of x-rays? Do you want x-rays? Do you want DEXA scan? We talk about EOS scan a lot. You're very familiar with that. Would you like that as well? What are the things that you'd like to see as far as a patient is interested in coming into you?
I'm using DEXA for the women after 30 years old, systematically for all the women, because I have two cases in my experience of subsidence on multi-level ADR in lumbar, with subsidence in the end plates due to lack of bone quality. And nowadays I'm doing DEXA systematically after the age of 30. and that's it. After, what we need is MRI, CT scan, and also full spine X-rays. In France, we use EOS X-rays, and I think you are aware of that. But EOS is probably expensive, and we can use full spine X-rays. It's enough. AP and interdigital.
Sure.
That's enough.
And then
after sometimes it could be interesting to know if patient had injection for facet block or things like this, but we can do it by ourselves.
And then if you get a patient that has a DEXA scan, say a woman of 43 years old, she has osteopenia or osteoporosis, would that contraindicate them for not being a patient with you? What are your kind of guidelines when you see that DEXA scan?
There is no problem. If there is osteopenia or even osteoporosis, we can implant prosthesis, but we have to prevent subsidence during cement, during the surgery and implant cement.
And then, or do you ever use a vertebroplasty like you see in some of these situations?
Yeah.
Have you do use vertebroplasty? Because that's kind of 50-50 out there with some surgeons. Some don't use it at all, and some do. So
we did probably the first in the world with Thierry Marnet. It was 18 years old.
18 years old.
Yeah, he called me. He come to my clinics. He say I have a very difficult case, and I help him to operate the patient, and we implant. We use cement in the bone to reinforce the bone for the patient, and we implant multi-level pro disc. I remember we are quite 18 years old.
And when you do the cement, do you do anterior or posterior?
Anterior, of course. When the first time I prepare the disc place, I implant the prosthesis, and then I put my cement just very, very close to the end plate.
Sure. And then
all the device, all the ancillary material of the kyphoplasty with the bone filler, and I'm using it's very safe. There is no risk of cement leakage. There is no, because it's very safe.
Do you, as far as failed revisions, as far as maybe, some of the charités out there, have you done revisions and for some of these patients that came in, 10, 15 years ago? And I guess, what have you seen? Obviously you've seen a lot more failed surgeries here in our group, but have you seen many failed surgeries in your clinic, and what have you done for those situations?
It depends. I did. It was in the SS in New York in 2004. I did a presentation on the strategy in case of revision, and I separate different situation. The first situation is the failure of the disc, but only on the X-rays, but without any consequences for the patient. If the patient is not so bad and it's only a problem of X-rays, we don't care about it. We don't have to make a decision only for X-rays. The problem, we indicate the revision if there is a risk for the patient with the failure of the implant. Okay. Sometimes the only pain, I'm not sure that only pain could be a good reason to make a revision, because it's difficult to know that pain is coming from the processes.
Sure.
And that is the most difficult part of the job.
Sure.
And always in case of failure of surgery, if a surgeon had made a surgery and the patient is not good, the patient came to another surgeon, you say, okay, you're not well because you have a bad implant. Difficult to know that. This is, and I'm not sure that the fault is always on the implant. You know what I mean?
No, I know. And that's one thing, I talked to a few people, with this M6 phenomenon, whether it's a bad batch or you know, it's just whatever may be going on there. We'll talk about that. Is you know, if your pain isn't bad, leave it alone. And most of these people that have, you know,
No, it's not leave alone. But if your pain is bad, try to improve it. Try to find the solution, the less invasive solution for you. A revision is not so easy. It's not. It's difficult. It's dangerous, and we're not sure that the revision drive to a good solution and alleviate completely the pain.
Well, I mean, you saw the one. I mean, you're familiar with the one Dr. Berg just did recently, so that'll be interesting. And you know, he's a French fellow, and we'll kind of follow him along to see how well he does. And you know, I know Dr. Berg did an excellent job, and he was demanding that was the situation. That was what the pain was from, because it was stuck. But you know, we know there's a few other patients that's had, you know, an M6 fail, and they're moving along pretty good. So I agree with you that it should only be in severe situations. When you're looking at a patient and they have bad facets, is that a contraindication for you?
It depends on what kind of implant you use. If you use a prosthesis with a great range of motion, like the Mobile, the ProDisc, the risk is to have painful facet joint. But if you use a prosthesis like the ESP is more a shock absorber than a motion device. Then the risk to have pain due to the facet is less. And then you can use, for me, ESP in case of facet degeneration.
Correct. And you would basically describe that as because there's less motion with the ESP.
Yeah, ESP is more a shock absorber, but it's you know, my mentor, René Louis, tell me, once I asked him, what is it for you, the antevertebral disc? He said to me, the disc is the biggest ligament in the human body.
It is.
Because it is the widest implantation.
And then
stronger the ligament.
Let's talk a little bit about, you know, I know you're not crazy about injecting stem cells and all these other things. And you know, if you remember way back when, Spine Art, and you're familiar with them because they're a French company, I think they had one of the first intradiscal injections, and I don't remember what it was made of. Do you remember it was like 10 years ago they came out with something? I may be dating myself even further along. They had an intradiscal, and you know, it wasn't ever approved in the United States, but I know that they were doing it a lot. Did they ever come to you about that, or do you remember seeing that at all?
No, I did in myself. One with the device was disco gel. I used it sometime with some good result. I don't know why, but sometimes I had a good result with disco gel. I think that the stem cells will be the future, but nowadays we don't know how it works, and we don't know how we can use it. As I say, you know, if you inject stem cells in the disc, in the generative disc, it's like if you inject stem cells into stones, because there is no vessels, there are no nerves.
Right.
How can grow the stem cell? I don't know. What is the mechanism of growing of stem cells in this kind of milieu? How to say that? In this situation, I don't know. I don't understand how the stem cell can grow. You know what I mean? Because there is only fluid, only water.
Yeah, I don't think that they're expecting to grow necessarily stem cell. I mean, to grow the intravertebral disc. I mean, because you have to have, you know, there's no collagen in blood and stem cells, right? And that's mostly what, when you look at the cartilage on the end plates, you have cartilage, and then you have a bunch of you know, matter, like you said, and it's mostly water with some other different cells. But I don't know, you know, injecting those cells. But like you said, with the visco gel, sometimes some patients have great results, and
we are lucky sometimes.
And I think some people get lucky with the stem cells, and it gets rid of their pain generators, and
it's like the placebo effect. I think nowadays the effect of stem cells is the placebo effect.
The placebo effect. Yeah.
Same rate of same percentage of improvement. It's like water is the same.
So let's talk about why do you use the Pro Disc, and I think we covered that a little bit, but I think if you go to give me your whole explanation, because obviously we have patients here in the U.S. that only have a Pro Disc, and then if they're interested in the ESP, they have to come to Europe. Why do you choose the Pro Disc, and why do you choose the ESP in your clinic as of today?
I used the Pro Disc because it was the first very easy to implant, with a very good ancillary, with a good result, and it was so easy to use it. Then the ESP is a very old concept. The concept of ESP was coming from Raymond Roicamy from Paris. At the beginning of the talk, we spoke about 3 pioneers of spine surgery worldwide. The first was René Louis, the second was Sénégas in Bordeaux, and the third was Raymond Roicamy in Paris, La Pitié, Salpêtrière. And Roicamy think about this replacement is more like a shock absorber. And my mentor, René Louis, did the prosthesis. It was the same than the Pro Disc. What the French, or the French team in the south, it was more like a ball and socket, and in the north was more the shock absorber. That's it.
Yeah.
And then for me, it was an evolution. Even I evolved to the ESP. I'm not changing because I keep some indication of Pro Disc always, because the kill is very interesting. In case of revision, if you want to make revision, the kill is very safe and secure system to lock the prosthesis into the level. And the ESP for me like an evolution of the Pro Disc, even if it's old concept. And we don't need too much motion. That's it, the problem. We don't need 25 degrees of motion on one level.
Yeah.
If we have 5 degrees, it's enough.
Right.
And when growing old, we saw that we reduce the motion of the body, and then it's an evolution like this.
Well, I think a lot of people don't realize that when their discs begin to degenerate to severe or moderately severe, that there's no motion in there already. So, they don't realize that whatever they get is going to be much better than that. Even with the ESP, they're still going to have a much more motion that they would typically. I mean, that's definitely in my situation. I'm almost bone on bone on one level, and the other 2 levels are pretty bad. But I know once I get a couple levels done, my motion will be much, much better, even with the ESP.
I want to tell you a story. Once
Sure.
in a meeting, a surgeon, a friend of mine from Switzerland, showed me an X-ray. It was a Charité implanted 15 years old before. 15 years before, and he said me there was the body bridge between the prosthesis, and the patient was very nice, and the patient was 75. And what do you think about it? What can we do? Nothing. It's a normal evolution of a disc, of a normal disc. After the age of 70, 75, all the discs are fused because the body protects itself.
Right.
For motion, and then when we growing old, we lost motion just to protect ourselves. That's it.
Yeah, I guess so. You've been implanting the Pro Disc for how long?
I start in 1997.
So obviously, from 1990, we'll say 10 years, 1997 to 2007. Do you see many of these patients come back, or?
Yeah, yeah. Now I saw patient from 1997, and they say it was fantastic to have a pro disc disc replacement, and they are still very very happy. Even if they have some pain, they are older, but they spend 15 years very very nice.
Yeah, so because that's one of the big questions that everybody asks in the group is how long these things going to last, and where's the data on the patients, and that's the beautiful thing about you is you've been doing this for 25 years and you've been inserting the Pro Disc, and even though it was the first generation, and I don't know if I've ever really seen a first generation Pro Disc to see the differences, but I don't think there's much difference, right? Yeah. Between the first generation and the second generation.
Two keels. That's it. And the core was not a sliding cord; it was a cord just put on it, and it was more difficult to implant than the second generation. Yeah.
And how many? I guess let me ask you this: how many cores have you?
65 patients. Only 65 patients at the Pro Disc first generation.
Oh, 65.
Yeah. And it was very very bad cases. It was patient with a long history of sad surgery, more than 3 surgery. It was the worst case in the world. And they had very, very good result. And patients say, just fantastic to have this. And then they continue to tell this 20 years after the surgery. We lost 40% of the patient after 10 years. And I contacted 40 patients after 18 years of the surgery, and they say, "Oh, it was just amazing to have this surgery." Of course, nowadays we have other pain and some pain in the back, but it's completely different than we had in the past.
Sure.
This is very important, and even with the Pro Disc 2. And even with now the ESP, when you operate patient with disc replacement and he has a good result, if you see him 10 years before, he will tell you it was fantastic to have this operation.
And then
if I have to choose, I do it again.
Sure. And that's the best answer you're looking for. Did you implant any of the ESP without the lordotic curve to it? The first generation, I guess, of the ESP, or you were after that?
No, I didn't do the first generation ESP. No. I didn't.
And how long have you been placing the ESP?
Now it's 3 or 4 years. 4 years. 4 years. Now.
And so you're kind of one of the lead guys there that go and train everybody throughout the world. And I mention this because I think it's pretty interesting because you being from France, and and I tell everybody I think some of the French training is far superior than most of any country. But you've been in all these countries, I don't know, 40 countries or so like that, training on the ESP. Have you seen a lot of bad things out there that I guess when you run into someone in a country, we'll just say it's wherever it is.
I don't want to make the criticism of no, but when I look some X-rays on the group, it's easy to see that the surgeon who implant the prosthesis is not completely aware about what is the prosthesis and what are the prerequisite to implant the prosthesis and what we need to have a good implantation. That's it. I don't want to say more because
I understand.
I don't want to have critique on the others.
And I'm not. I guess I wasn't really trying to go there. I was just trying to say is I was just trying to look at your training that are there some people that you when you leave say you leave a country that you would say, well, I don't know if it's going to go too well there.
Yeah, sometimes you say, okay, this guy would be a good surgeon for implantation, and you say sometimes no.
Okay, that's what I was kind of looking at. And I think you've trained. How many surgeons you trained in your lifespan?
I spend between 150 or 200. I don't know where this for me this.
Yeah, I think it's important for people to understand, what a legend, and I call you a legend in a way, and I think it's a big compliment, but of how much you've done in the spine industry, you know what I mean? And people, I think, really need to realize that when they're looking at surgeons, what are the things that they need to look for? And you've been and you've seen it, and you're a master of disc replacement. So I'm just trying to, show your credentials there, because I think it's very important that people realize that. And that was the reason why I spent, I think it was like 8 hours from Le Mans to Marseille to meet you. I mean, I think you
10. 8 hours, you are fast. Too fast.
I had an Alfa Romeo. I got lucky with Avis in Paris getting that car, but for me it was also an adventure to see France, right? It was beautiful, and I always tell people I don't think there's a better city to recover in than Marseille, France, because it was just extraordinary. It's the south of France, and the views and the scenery and the people were fantastic. And I tell everybody there that they'll have a splendid time, with the ocean and the backdrop there. And there's a lot of things that I felt like similar to the West, where there was restaurants that were a little bit westernized with the food, and then there was, of course, the classic French restaurants. I just loved your city. Out of everywhere I visited in France, and I visited, I went to Dijon, and then I went up to see Dr. Ricard, and then I went to see Dr. Smits, and I spent time for the group, myself, just driving around, and it was lovely. And me and my wife, and we went and saw that large church. I can't remember what it was, but it was quite lovely. So I'm just trying to talk to the scenario when you go there. It's your pain will be gone, because you're going to be just enjoying.
I can invite you again in Marseille if you want.
Yeah,
it will be a pleasure.
So let's talk about some of these situations. So let me ask you this, and I'm trying to. Some people wanted me to ask you some questions. Say a person is, I got to get my 152 centimeters, which is about 5 foot to us. What disc do you use typically? And is there a disadvantage of being so short with these discs? They're typically maybe a little too large for them.
We have always a solution to when we implant the prosthesis. If the prosthesis is not good for the patient, we don't have to only. My aim is not to absolutely to implant the device. My aim is to do something good for the patient. If the device is not adapted to the patient, I will change the device. And if the prosthesis is too large or too wide, etc., can do a fusion. And the result will be quickly the same, because if we remove the pain generator is a disc. And if you remove it and completely, if you do a great job, when I'm doing a fusion, I'm doing the same type of disc resection than for the prosthesis. I do the same job, but what is only changed is the device. If my device is too big, not adapt to the patient, I can stop. It's not. I don't want to use screws, this kind of thing, to avoid any this kind of slipping, and to try to fit the best I can the process. And I ask to FH to develop. I'm going to develop something to replace the screws that sometimes we saw in some X-rays to stop the processes, because I think it's not. We can do better.
Do you happen to have? Are you in your clinic right now?
Sorry.
Are you in your clinic right now in your office?
No.
Because I was wondering if you had a stand. I guess you would use a standalone cage for a fusion, and I always thought it'd be nice to do a little show and tell of a stand. If you have a standalone and an ESP and a Pro.
It's difficult to show you. I have my computer, but what can I do? No, I'm not stand here.
No worries if you can. I could have told you about this before, but it just kind of hit my mind.
I can send you X-ray if you want, but I'm not there.
Yeah, no worries. So there was another patient wanted me to ask you a question. So they had an implant of M6 cervical, and the surgeon, and I asked you this I think prior, the surgeon placed the disc too far anteriorly and hit the dura, and then pulled the disc back out and placed it. The reason why we kind of know that is because the MRI showed that the dura was damaged, and she's a younger girl. So is there anything? Is it just mostly time, or what do you suggest for her? What can we do for her? Is there just? I guess that's a question.
I would like to see the X-rays, because it's difficult now to speak about something without to see exactly what is it. But what is now? Is there neurological problem? What kind of she has neurological impairment?
Yeah, she's having some numbness and dizziness, and she's losing some control in her arms, and
she has pain, always pain in the cervical.
Yeah, she's a young girl, and she's not able to even work right now, and that's the part I have a hard time with, because we need to make a living and work, and she's trying to be a productive person, and it's and I think it's gotten worse from what she's told me.
We need even some dynamic X-rays to see what the behavior of the implant, and if there is some instability, something that's wrong, we can remove the prosthesis and to replace, or by a new prosthesis or by a fusion. But difficult to see something without seeing the X-rays.
Try to just make sure I've covered everything. So let's talk a little bit about the disc migration that we've seen with the ESP, because a lot of people are very curious about that. You see some folks using screws to kind of hold that in place. I knew years ago that there was a surgeon that was using the screws mostly for very small patients to kind of hold those in. And what is your findings, I guess, on that, and what do you suggest, and what do you think is the cause of that?
I think if we surgeon use screws because the patient are too small, I think it's a mistake. You have just it's not my way to do surgery. I'm not driving by the device, but I'm driving by the patient. The patient is my priority, not the device. If the device is not fitting well in the patient, I can use it. We're not obliged to use a prosthesis. We can say to the patient, the prosthesis was not well. I prefer to use something different, but will be better with that. The risk with the screw is to create a reaction between metal and metal, like metallosis. And metallosis is not a good thing.
No.
And we saw metallosis with the Pro Disc in case of poly and snap. And when you have L plate on N plate, and I removed revised three kind of processes of Pro Disc, and there was metallosis between the two end plates because there were no more polyethylene. And this could be a concern and an issue. But for me, using screws, if you are you're scared of sliding prosthesis, that's a problem of technique. Most of the surgeon have to don't implant perfectly the the ESP forming. The ESP must be very close to the posterior edge of the vertebra. It is a more stable position for the DSP. If you put the prosthesis 5 millimeters forward, the risk is to have a sliding effect. It's not systematic, but it's more risky. And I don't know how if in US they use brace after the surgery. I'm not aware of that. Have you information about it?
No, I guess I don't know.
With last neck in Paris, we use brace to avoid the risk of gripping for 3 weeks, and because this process is very unstable in torsion.
So I guess I was misunderstanding. You use a brace for 3 weeks.
Yeah, a very soft brace, just to for remaining for the patient to know I have been operated. Okay, but they can do what they want with the brace.
So do you recommend the brace even with the Pro Disc?
No, because the keel was
right. We'll lock it in.
Stable, yeah.
Yeah. So I just wanted to make sure. So anybody with an ESP comes in and they got to wear the brace for 3 weeks.
Yeah.
With you.
You know, in the beginning with the charity, those who are using the charity say we have to put brace on the charity just after the surgery. Wow.
I guess, let me ask you this. Why only 3 weeks? Do you feel like after 3 weeks, and we can maybe talk about the mechanics behind that, after 3 weeks, do you feel like there's a bond that started enough with the ESP?
Because it's just the time for healing, for tissue healing. It's like ligament healed in 3 weeks.
Oh, 3 weeks.
Yeah, but you have just like a sheet of ligament around the processes, and then stabilize. It's enough to stabilize.
So then I guess anybody that goes and gets an ESP after 3 weeks, they get an X-ray, say after 30 days, and that disc hasn't moved, they should be good, is what I guess I'm asking. Correct?
Yeah.
Okay.
Even if there is a sliding of 2 or 3 millimeters, it's not an issue. It's not even there is just like a sliding of 2 or 3 millimeters. For me, it's not a problem.
So let's
it will be at 3 months.
Let's circle back just to this M6 phenomenon, because I know there's a few members that is still interested in getting their M6 removed, and say that we know that the M6 is causing the pain, and there's some cases, I don't think you may have seen them because they're not recent, but we have a few patients that have a lateral tilt to their spine, so they develop scoliosis from the M6, and obviously they don't want that scoliosis getting worse. What would you suggest to do for them, or what would be your revision strategy?
Revision strategy is depend. Is there a painful patient most of the time or not?
Yeah.
But I'm sure that we can say that the pain is coming from the scoliosis or not. That's the problem. Sometimes it could be a muscle pain due to the lateral bending. You know what I mean? It's like a cramp in the muscles.
Sure.
And we can first try to work on this with physiotherapy, with a lot of things like this. And then we have to work on it. And sometimes use physiotherapy to try to put the patient on the other side. Like soft technique before surgery.
Sure.
And in case of pain and then a very, very large scoliotic deformity, we can do something, of course. We can do only by posterior, and to try to reduce the scoliosis by posterior approach. And then if there is always pain, remove the cage, the prosthesis by anterior, then start by posterior for reducing the deformity, okay? And anterior to remove the prosthesis if needed. There's still pain.
Sure.
But in case of deformity and problem of only scoliosis, it could be better to reduce it by posterior. It could be safer because the anterior revision is more difficult, is very risky, and trying to use this for scoliosis difficult.
Do you use dynamic stabilization at all? You know, any of the?
I did that. I was using dynasis, some also dynamic screws. Yeah, I did. But
Still?
no, I stopped it. No. Now my dynamic is prosthesis.
Okay. Okay. Well, I think that's it. I think we covered everything we need to, and we're exactly an hour, like I always am. I don't know how it always works out that way. And I want to thank you a lot. And like I said, I know our patients in our group are very happy to have you in our group and giving us all your great insight. And when a patient's obviously, let's go through this again. When a patient's seen this video, what's the best way to get in touch with you? Is your email, I would imagine?
Yeah, email or anyone. Email is good.
And then do you want to give us your email?
Of course.
You give me your email now. I don't know.
Tropiano. Tropiano. Can I write it now? I can. I can write it. No.
I think it's. Hold on.
Can do something here? No. And to use something like this. Please wait. Do you see it?
There we go. It's
you got it?
Patrick.Tropiano at ap-hm.fr. And we also have you on our locator, the surgeon locator. And then typically, how long does it take you, because patients aren't patients, they have no patience whatsoever. So I always tell people, how long does it take you normally to respond at a maximum? A week?
For respond?
Yeah.
Oh, if somebody send me a message, I can answer it the same day.
Okay. Let's just keep it at a couple days, just in case, because some people still, what if you're traveling and you're in Morocco?
I'm trying to answer the same day.
Okay. I appreciate
Even
that.
if I'm outside and.
That's fantastic, by the way. That's very gracious. And then normally, we don't talk about cost because every patient can be a little bit different. But someone talks to you, you give a evaluation, you give a plan. How much time do you normally need to schedule? Or usually about 30 days out, 60 days, 90 days? How full is your schedule?
No, it's going to be between 2 months. Yeah.
How long?
60 days.
60 days, typically?
Yeah,
because like I said, I know you travel a lot. You're doing some traveling in January and February, but I know you're getting a couple patients then. And then how long typically with cervical would you like a patient to stay in the hospital?
For me, in the hospital is between 2 or 3 days. If it is one level, 2 days it's enough. Multi-level is better 3 days. And then I want also that the patient stay 1 week closer to me, close to the hospital. Then they come to my department to make physiotherapy, and I can check that everything is fine.
And then what about if you're doing a lumbar multi-level or single?
No, lumbar is for 1 level is 3 days. And in multi-level, it could be 3 or 4 days, 3 or 4.
And then how long do you want them to stay there?
1 week or 10 days close to me.
Okay.
Just and then to check that everything is it's fine without any complication. They can start some physiotherapy in my department, and the CC is free. There is no fee for that.
Yeah, and just to kind of give it patience, your pricing is probably the best out there, at least at this point. Once again, Merry Christmas to you. I hope you have a great holiday. And then,
Joyeux Noël.
yeah, are you going to Puerto Rico in February?
Yeah, I would like that. I'm going to try. I'm going to ski before in Japan, and then I'm going to Puerto Rico.
All right. Well, I'll definitely probably see you there, and we can talk some more and see how things are going. And I look forward to it. Let me get the recording.
Okay.
All right.